Okay, now the genetics of the partial mole. As we came to know, the complete mole is a diploid in nature, and most probably it is androgenic and less likely biparental. And once it is androgenic, most likely it is monospermic and less likely the bispermic or dispermic, right? So as we see the partial mole is a triploid in nature. What happens here? Actually, two sperms, not chromosomes, sperm fertilize an egg which is having also a genetic material. So the net result is triploid. In the same way, three sperm can fertilize the single egg and the result is the tetraploid. Very less likely there is a mosaic pattern as well. What happens when the different genetic material is present in two cell series in the same individual? It is termed as mosaic. So mosaic can be present in partial mole, but very less likely, very rarely, but it could be. Now, what are the clinical presentation of the gestational trophoblastic disease? The most common presentation in patient with the gestational trophoblastic disease is amenorrhea followed by vaginal bleeding. And second common presentation is patient is having incidental finding of molar pregnancy over the ultrasound. But the less common presentation is these patients are namely hyperemesis gravidarum, right? Early onset preeclampsia, excessive fundal height, hyperthyroidism, anemia. These are the less common presentation in gestational trophoblastic disease. Hyperemesis gravidarum, why it happens? As we all know, there is an excessive release of beta HCG because of abnormal proliferation of the trophoblastic cells. And this is beta HCG which is responsible for this excessive sign and symptom of pregnancy. Excessive vomiting pregnancy, which necessitates a patient to be admitted in a hospital, or which leads to the electrolyte imbalances, or which leads to the loss of 5% of weight of patient. This is termed as hyperemesis gravidarum. Second, early onset preeclampsia. This is one of the condition where we found early onset preeclampsia along with other condition which can be found in other condition as multiple gestation or the antiphospholipid syndrome. So because preeclampsia is placental based pathology, we all know, and molar pregnancy is also placental based pathology. So preeclampsia is commonly seen in such patients. There is excessive fundal height in these patients. Because of abnormal proliferation of trophoblastic cells, the fundal height excessively increases as compared to the actual gestational age. Patient having 2-month amenorrhea, but she's found to have 14 or 16 weeks size height of fundus, which is not corresponding to actual height of actual uterine size, actual gestational age. Okay, why the hyperthyroidism occurs? Actually, what happens? The HCG, which is excessively released in the gestational trophoblastic disease, having the alpha component similar to the TSH, and this excessive TSH stimulatory effect lead to the excessive release of thyroid hormone and thus the hyperthyroidism. Patient may present with the hyperthyroidism. Patient may present with the anemia because of the excessive bleeding. These are the least common presentation in gestational trophoblastic disease. Rare presentation. Rare presentation in patient with the gestational trophoblastic disease are respiratory collapse. Why this happened? Because of trophoblastic emboli to the pulmonary circulation. Second, seizures. Trophoblastic metastasis towards the brain.